Hello everyone. Welcome to the Moved Mobility video series. My name is Gina Edwards and I work with Dr. Tony DeGioia at the Innovation Center, where we conduct cutting-edge research on bone and joint health. Together at the Bone and Joint Center, we are committed to continually improving patient experiences for each and every one of our patients. The combined expertise of our patient community with evidence-based research guides this ongoing effort. One area of inquiry in particular has been health disparities that relate to gender. In this episode, we will explore how gender relates to differences in the evaluation, diagnosis, and treatment of bone and joint conditions. So, what are the gender differences related to these issues? Recently, Dr. DeGioia, Medical Director of the Bone and Joint Center and the UPMC Innovation Center, presented our latest research and findings on these gender-specific topics to the dedicated nursing staff at UPMC. Let's turn to that presentation now, where you will find answers to your questions.
This is an area that we actually have become very involved with over the last year, and I'll explain why. So the subtitle of this talk is Gender-Specific Care for Hip and Knee Arthritis and Joint Replacement. And it turns out that your sex, male or female, does matter when it comes time to both have an evaluation for your hip or knee pain, for both how you exercise and how you perceive pain, but also as you go into the surgical side and how you prepare for surgery. And it turns out it also can affect outcomes too. So we, about a year ago now, we've launched a special program here at Magee, and no better place to do this than Magee, on the gender-specific disparities when it comes time to evaluate evaluate and treat hip and knee arthritis and possibly surgery. So what's the background? So gender-specific is a little broader than what I think you initially would think of. By definition, gender relates to many factors. It relates to a patient's lifestyle, their behavior, and habits. So it is more simply than being just male or female. So these are just some of the facts, and there's it's really surprising when we did our background research into this, because this all comes from our literature. So it's actually been there for quite some time, but I think that it has not been recognized in the level of disparities, and certainly there haven't not been programs to address the disparities. But just to give you an example, 26% of women have arthritis versus only 18% of men. Women are 3 times less likely than men to elect to have a joint replacement. However, for several reasons, 60 to 70% of all our total joint replacements are women, and they have unique challenges when it comes time for surgery that we will discuss. Because when women elect to have a joint replacement, they are typically older, they're typically weaker as far as the muscles, they're typically a bit more frail than men, and they also report worse pain and have worse preoperative function scores, which we always measure on patients, whether you're male or female. So what this means is that when it comes time for surgery, typically women are less prepared for their surgery, are starting in a worse position. And what we found from our research studies using patient-reported outcomes is that if you start at a very low position before surgery, you may not see the maximum benefit of the surgical intervention when it comes time to cure your arthritis with a joint replacement. One of the factors that really has also come through is there is a marked difference between when women versus men decide to have their hip or knee pain evaluated. Now, this is just pain. It doesn't mean they have to have arthritis. But number one, as we said, women are more likely to develop hip and knee arthritis than men, but they're likely to delay seeking an initial evaluation and treatment for their pain compared to men. And then when they do present, they have more symptoms, more severe pain, more chronic pain syndromes, and a greater loss of function. Men are more likely to have an initial evaluation earlier, and they're also more frequently elect to undergo a joint replacement. They tend to have better pain and function scores at the time they decide to have surgery, which may mean that, again, they're having earlier evaluations and diagnosis and treatment plans, and it prepares them better for surgery. And I can't emphasize enough the prevention part of this. We're not just talking about patients that need surgery, but the earlier you have an evaluation, make the accurate diagnosis, and institute treatment plans, the more likely you will reduce your pain, increase your function, and slow the progression of the degeneration, meaning prevent you from needing surgery earlier than later, but still maintaining an active lifestyle and an active function. So it's an important theme, I think, that you need to take into account. And there's definitely gender-specific disparities. So, then if you go to the next level and say, why are these differences? Okay, what explains the different incidence of arthritis? What explains why women are less likely to have an evaluation? Well, there definitely are anatomic differences. We know there's definitely anatomic differences between men and women, but there's also difference when it comes to the musculoskeletal systems, and particularly hips and knees. So there are anatomic or physiologic reasons. The disparities are also related to the availability of education, how the information is presented, the anxiety that's generated about findings, or women, a factor that women tend to take care of others before they take care of themselves. But the delay that, for whatever the reason, reduces the opportunity for these early interventions to slow down or prevent the progression, and certainly to reduce pain. So if you look at the preoperative part, or in the early evaluation part, what the literature supports is that women tend to ask more questions about pre- and post-operative care. They're more affected by osteoporosis than men, as you know. They have worse quadriceps function around the knee, and that's that muscle in the front that allows you to straighten your knee out. And there's worse abductor hip function associated with hip arthritis in women, and that's the muscle on the side that allows you to go and walk normally without a limp. There is lower preoperative function scores, and if you have these low levels to begin with, you may not see the maximum improvement. Excuse me. You may not see the maximum improvement after your surgery. On the contrast, men tend to have these higher overall functional scores, and they definitely have better muscle strength. So these are the disparities, and it's important, number one, to recognize them, but then the next step too is you want to develop programs to address these disparities. What are some of the similarities? So it's not all different. There's no differences, for instance, in how long implants last in hip and knee replacement, even with those gender-specific types that we talked about. So if you elect to have surgery, whether you're a male or female, we still have the long-term outcomes that are improved across the board, despite whether you're a man or a woman. The quality of life improvements are very common, are very similar in both groups. The only condition of that, like I said, is if you start out at a very, very low functional level and very high pain level, it is a much harder hill to climb for women to achieve the same levels of increased function and decreased pain because of that starting point. After surgery, so what we have found is there's slower improvements. The activity scores lag behind men as far as what they do. They have these persistent gait abnormalities, which are related to those muscle weaknesses that I talked about. Pain is definitely perceived differently if you're a male versus a female, both preoperatively and postoperatively. Remember, our patients by definition have chronic pain, which is any pain greater than 3 months from a medical definition. But how patients, whether you're a man or a female, handle a chronic pain is very different. And women tend to develop what we call chronic pain syndromes, that can affect their perception of pain postoperatively as well. On the medical side, women are more likely to develop a UTI. They're more likely to develop a blood transfusion, although that's still a very, very, very low rate. And many times they need to go to a non-home discharge, meaning possibly to a skilled nursing facility for a few days versus going directly to home. So what about after surgery? Some of the statistics for men now, they're 15% more likely to return to an emergency department in 30 days. They're 25% more likely to be readmitted. 60 to 70% more likely than women to have a heart attack within 3 months after surgery, and 50% more likely to require revision within 2 years, which is a very early time frame, following a knee replacement particularly, and also more likely to have experience an infection. So there are differences in the clinical side too, and these are kinds of things that we'd like to address. So what have we learned so far? There are these definite gender-specific differences and disparities, but these present opportunities for improvements in patient care pathways. So we need to improve the outcomes for both the non-operative and operative treatment based on these disparities and the patient populations. Most importantly, and directed at the women, is that earlier evaluations and diagnosis are important. And we always say you need to know where you stand before you can provide a treatment plan, but it is well worth having an evaluation to see where you stand and hopefully slow the progression of any degeneration and make you feel better. So the programs that we have been developing here at Magee to address these, and it's very unique. We don't know of many programs that are taking the time and effort to understand the disparities, develop programs for it, but importantly also educate patients, the community, and providers, because there's a lot of misconceptions in the providers. So we're promoting earlier evaluations, as we mentioned, in low stress settings so that we can provide these individualized care plans, customized educational programs that include shared decision-making tools, because we do know that women and men process information differently, gender-specific prehabilitation and exercise programs. Stacy from our gym upstairs, she actually already has instituted and emphasized the prehab program for women, and then she's also implemented the program as an inpatient in the inpatient unit upstairs. Programs in pain management and alternative therapies is an area that we're again exploring, because pain management and pain perception, particularly when it comes to chronic pain syndromes, can affect both the treatment of arthritis, but also what happens after any surgery. And we use a process called co-design, in which we actually engage patients and families by asking what matters to you as a tool to determine the factors that most matter to patients so that we can focus our clinical programs. As part of that, you're the first group to really see this slide. We have a new effort here at Magee, and it's a new Center for Bone and Joint Health. And it's very unique in that it's called a virtual center, meaning it doesn't require additional space or that kind of thing, but it brings together 5 departments that have common missions, all to focus on your bone and joint health. So we have engaged with bariatrics and nutrition, the Midlife Health Center, the Osteoporosis Care Center, Pain Management and Alternative Therapies, and the Bone and Joint Center together to develop collaborative care programs, education programs, and training programs to address these disparities and develop programs for your bone and joint health. And it's a program that we just started within the last couple months with the support of Magee's leadership. And we hope to be able to talk more about this special program in upcoming sessions.
We hope you enjoyed watching this informative presentation. As we continue to explore this topic and develop interventions to address these disparities, we encourage our community members to contribute their knowledge from lived experience with bone and joint pain from arthritis. We invite you to join our community by signing up at amd3.org. You will receive information about our education programs, cutting-edge research findings, resources and supports, as well as opportunities to get involved with or contribute to our research. We are proud to be working on this important area of orthopedic health and hope that you can join us. Thank you for watching this episode of Move to Mobility. We'll see you soon.